Good afternoon, good morning, good evening, and welcome to today's NIH Common Fund Discovery Dialogues webinar, Transformative Approaches to Address Health Disparities. This is the inaugural webinar of this new quarterly series designed to highlight groundbreaking NIH Common Fund scientific advances and program outcomes. My name is LaShondra Price, Assistant Director for Re-engineering the Research Enterprise in the NIH Office of Strategic Coordination. Thank you so much for joining us today. It's my pleasure to introduce Dr. Vivian Ota Wong, Acting Director for the Office of Strategic Coordination, who will provide opening remarks and introduce the NIH Common Fund. Dr. Wong joined the Office of Strategic Coordination in May of 2025, and prior to joining the Common Fund, she served as the Permanent Deputy Director of the NIH Office of Research on Women's Health. Vivian, welcome.
Thank you very much, Alessandra, and good afternoon to everybody. I am Vivian Ota Wong, the Acting Director of the Office of Strategic Coordination, also known as the Common Fund. I'm really happy to welcome you all to the Common Fund Discovery Dialogues webinar series to highlight groundbreaking NIH Common Fund scientific advances and program outcomes. Each session, importantly, will spotlight research that is accelerating discovery, fostering collaboration, and expanding what we know about human health and disease. I'll now provide some brief background of what the NIH Common Fund is and the unique entity that it supports, that it supports the transformative research to address health disparities program and other innovative efforts like it before introducing today's speakers. Next slide, please. So here we go. The Common Fund really supports bold science and catalyzing discoveries. It moves the NIH mission forward faster by supporting bold and innovative scientific programs that are truly designed to catalyze discovery in areas of research relevant to the NIH mission. These areas of research are cross-cutting, rather than focusing on one disease or organ system, and advance the missions of multiple IC institutes and centers simultaneously. Common Fund programs are designed so that each deliverable will spur subsequent biomedical advances that otherwise would not be possible without our strategic investment. Common Fund programs support uncommon approaches by catalyzing discovery and research solutions. In order to carry out these uncommon, what we're calling uncommon approaches, our programs must meet the following criteria, and you see them illustrated on the right side of the slide. They must be transformative, which means they have to have high potential for exceptionally high and broad impact across the biomedical and behavioral research areas. They have to be catalytic and time limited, but they also have to be ambitious and goal driven. And these programs are supported by investments for up to 10 years and are designed to capitalize on new scientific knowledge or breakthroughs to enable, accelerate, or significantly change the trajectory of subsequent research. It's goal-driven. It's focused on specific outcomes to advance science, such as new knowledge, new data sets, resources, methods, or technologies. Dynamically, it's synergistic, that where we are advancing multiple institutes, centers, and offices missions, and leveraging the multidisciplinary expertise from these different institutes, centers, and offices to truly accelerate the research relevant to multiple diseases and conditions. And last but not least, is that things have to be novel, because we want to pursue innovative solutions to specific scientific challenges that no other entity is likely or able to address. Next slide, please. This to me is a very exciting slide because it really shows and is meant to convey the nearly overwhelming breadth of scientific areas covered by past and present Common Fund programs. And what you will see is an illustration that it really does cut across a wide breadth of scientific areas and disciplines, really making a difference in the research for health and human disease. Next slide, please. So this is some examples where these are Common Fund supported science, and to really illustrate the broadness and the high impact. But it is because it's meant to be high impact. What we're looking for is ways that we're going to alter the trajectory of whole fields of biomedicine that will yield discoveries that improve health. So just as some examples you will see listed below is that we have advanced issues around clinical trial design, biomedical research training, genome editing, exercise research at the molecular level. So next slide, please. So once again, I just wanted to welcome you to the Common Fund Discovery Dialogues webinar series. And now I'm going to hand it back to LaShondra to introduce today's speakers. Thank you.
Thanks so much, Vivian. I'm pleased to introduce our first speaker, Dr. Poorna Kushalnagar. She is the director of the Center of Deaf Health Excellence, strategic research officer, and professor of psychology at Gallaudet University in Washington, D.C. An internationally recognized public health research scientist, she leads federally funded research focused on improving health outcomes among deaf-blind, and hard of hearing individuals who use American Sign Language. Dr. Kushalnagar has received more than $15 million in total support from the National Institutes of Health and has more than 100 peer-reviewed publications. She earned her bachelor's degree from Gallaudet University and her master's and Ph.D. from the University of Houston. She completed NIH-supported postdoctoral training at the University of Washington and the University of Rochester School of Medicine and Dentistry. Since joining Gallaudet in 2016, Dr. Kushalnagar has advanced cross-disciplinary research and institutional strategy as Strategic Research Officer for the university. Welcome, Dr. Kushalnagar.
Thank you for having me here. Good morning. First of all, I would like to start that our work was built with our community, not on our community. I want to thank NIDCD and NIH Office of Director for funding this work. Next slide, please. We all know this. Cancer screenings save lives, but the benefit is not equal across communities. Information is not often given to communities in plain English or in accessible American Sign Language. And this fosters a long history of medical distrust, being ignored and dismissed by the medical system. This has an incredible impact on health outcomes, delayed diagnoses, less preventative care, lower screening rates, and worse outcomes. This is the gap we set out to close. Next slide, please. As we begin, I would like to share one voice with you before we go further. And this is a cancer survivor reflecting on her treatment. There are no captions, I apologize for that, but we do have an interpreter that will interpret for those watching the video. Please start the video.
When asked during your appointments, what did access look like for you? Did you understand all of the information clearly? She responded, no, not at the time. The information wasn't really retained throughout the course of treatment. I went through the motions without really understanding the full details. Once I was finished with treatment, I was able to look back on my experience and reflect on what I did and didn't like. Throughout the process, I asked questions and still didn't understand because of the medical terminology they were using. The interpreters made an effort to translate the concepts and break down the medical terms, but I still struggled. It was tough. One strategy that the doctor used to help me was by drawing a picture. It helped a bit in understanding the concepts, but I still struggled with fully understanding the terminology throughout. That was the root of a lot of communication breakdowns, and it felt like that a lot during my treatment. Erin, you're muted.
Erin, you're muted.
That story was not a one-off experience. It is a common experience within many communities, and that experience shaped every design choice we made. Next slide, please. We designed this study about 3 years ago with three things in mind. First, that we would utilize ASL fluent navigators and that they would raise screening rates. Secondly, that they would help improve how patients experience communication with their own doctors, not just with the navigator, but with the healthcare team they see daily. And thirdly, we expected that gains in cancer knowledge would track with adherence. Next slide, please. Being partners with the community is incredibly important. This study did not start with an immediate recruitment effort. We actually had to build relationship within the community over many, many years. The navigators and researchers are deaf, hard of hearing, deaf blind, and are very involved in their own community. Our researchers went into those communities to listen deeply to the experiences of the community, which built a foundation of trust for this work. Upon commencing recruitment, we went to where the people are. So we attended conferences within the community, local centers, community events. We did not wait in a clinic for participants to come to us. Even though I am a member of the deaf community, we were coming in as researchers, and so we relied on local individuals to bridge that gap and to help us recruit individuals for this study. Each step of the process, advertisement, recruitment, any materials, were always provided in ASL and in written English, and we ensured that to community check those communications to ensure understanding within the community. Next slide, please. This map represents the original survey that went out. We disseminated it in 2 parts. We used a database, and at that time we had about 3,000 members, participants in our database, which received an email. We then subsequently traveled to many different locations to present and recruited over an additional 1,000 participants to take our survey. We wanted to identify those participants who were not adherent to the recommendations for cancer screening. Our participant pool was not limited to mainland the United States, but also included Alaska, Hawaii, and Puerto Rico. Next slide, please. Over 1,000 took our initial survey, and we identified many participants who had not yet taken the cancer screening, and we invited them to our clinical trial. 184 community members joined the trial. They represent individuals from across the United States and a variety of age ranges. We did a randomized control trial. Half of them were in the participant arm, and we utilized community health navigators for their experience with the screening, and the others were given the standard of care with no additional services. Next slide, please. This map represents the 184 participants who gave consent and subsequently participated in our RCT trial. Those hexagon shapes are the locations in which team members of mine traveled to conduct these surveys. The dots represent the participants who participated and responded to our survey. We thank the beloved community members who were willing to travel and participate in this important work. Next slide, please. So this slide is particular for the participant arm of the study. First, we conducted a video call with participants and we used the same script to explain the screening. And we had 2 or 3 screenings that they were not adherent on, but we asked them to pick one screening. And during that meeting, they also participated in a role-playing exercise in which they could practice questions that they could ask the doctor at their next appointment, areas in which they could push back for further clarity, and a variety of other things like scheduling and insurance issues and following through. Next slide, please. Here's what we found. Of the participants who were in the intervention, 91% of them worked with a navigator and completed their cancer screening. In the standard of care group, only 67% completed the screening. That is a 24%, percentage point difference, larger than what we had expected going in. Let me be honest about the numbers. Of the 184 participants who were randomized, 83 had complete data on the primary outcome. The rest withdrew or were lost to follow up over the course of the trial. However, the signal is strong enough that we are confident the navigator made the difference. Next slide, please. Our second question was whether the benefit lasted beyond the study itself. We asked participants to rate how well they felt they could engage with their doctor in communication. If the doctor listened well, if their questions were well met, if they understood the information they were receiving, and overall, we did see a higher rate of within the intervention group as opposed to the standard of care group. The sample size was small, so we do not have the power to show statistical significance, but the increase did show a trajectory larger than we expected in our original hypothesis, and we were happy about that. 3 things are happening here. There is a shift not just in communication, but it reflects 3 pieces of communication. First of all, it shows that decision-making is higher when you have a relationship and clear communication with the medical provider. They have autonomy over their decisions, what questions they would like to ask. And thirdly, they're able to ask for clear explanations about medical terms. And this skill transfers not just to the practice session, but to the doctor's appointments that they subsequently participated in. Next slide, please. This is an important point of our presentation. This was ad hoc. It was not a part of our hypothesis. We did not see this coming. But one thing that we learned during our work was that about 15% of the participants who at the time of taking the survey marked in their answers said that they had not yet been screened for cancer. We considered them eligible, then randomized them into the intervention group and the standard of care group. And as we progressed into that first session, about 28 of those participants who were pretty evenly split between the standard of care and the intervention group, 28 of them we realized had in fact already gone for cancer screening. Maybe they had had a colonoscopy just 2 years ago or a breast cancer mammography. And so they were in fact adherent. And this speaks to how that information is handled after the screening takes place. This says a lot about our community and the decreased access to health literacy and understanding each part of the process. That it's not just before the appointment, this information is important, but also after. The doctor, it's important that they follow up to ensure that they understand what the screening was for and what the results were. Next slide, please. Oh, excuse me, one back, please. I would like to take a moment to point out here that suppose we did not have a member of the team who used the same language. This adherence would have been missed. And so it was important to us to have researchers and navigators who could directly interact with the communication preferences of our participants. And I just wanted to share that with you. Okay, next slide. All right, I would like to briefly mention our 4 takeaways. First of all, information access is in fact a gap. When the language barrier is reduced, then the screening rates increased. Secondly, that peer-to-peer co-navigation experience developed skills that would transfer to the participants, being able to use those in subsequent doctor's appointments. Those skills stayed with them far after the navigator session was completed. Thirdly, trust-based recruitment is the foundation. None of this works without showing up in the community spaces long before a study exists. And fourth, having ASL fluent navigators who have lived experiences was important. It worked. If those individuals do not have direct communication, they were not completing those screenings as often. Next slide, please. I want to thank the community. I want to thank every participant and partner. I thank NIDCD and the NIH Office of the Director for funding this important work. This is our team at an on-site visit at Gallaudet University, and this happened about 3 years ago now. Our team has grown much larger and is further diverse than it shows here, but thank you very much for your time, and I open the floor for questions.
Thank you very much. I will start with a first question, and we ask that our participating attendees place their questions in the Q&A. So, Dr. Kushalnagar, you mentioned that some of the participants didn't even know that they had already been screened until they connected with your ASL Fluent team. What does that tell us about how screening status is communicated in routine care and the changes perhaps that are needed to close the gap between what we know to be effective from research and what we do or what is actually implemented in real-world clinical practice?
Thank you for that question. What those numbers tell us, those 28 participants, I believe it's not a gap in the screening itself. I believe it is the loop that was not closed after the screening. The format of results of a screening are not always caught by the deaf and hard of hearing community. Maybe those results were transmitted in written English, maybe they were sent in email or in the mail. And so if those screening results are not talked about in person, there might be a gap in understanding that the loop has been closed about that screening. I think it can be addressed through a brief phone call or an ASL video that is attached to those documents in the patient portal that just quickly reviews the results of the screening. And that would allow for higher health literacy and understanding and closing the loop of the need for the screening and also the results of the screening. That co-navigator was able to explain the process to our participants. And so I would just say that I don't think it's the screening that's the problem. I think it's the lack of closing the loop, if you will, that could be addressed.
You also saw shifts in how people communicated with their own doctors over time. From your perspective, what can clinicians and clinics start doing differently immediately to reduce information gaps and to especially to support deaf, deafblind, and hard of hearing patients more effectively?
I have four things to mention I think that clinics could implement tomorrow. First of all, they can immediately ask the patient what they would like, not to wait until the patient shows up and then find out if they would rather communicate through an interpreter or write back and forth, but immediately at the time of making an appointment, asking what the deaf person's preference is. I also recommend scheduling a certified deaf interpreter if one is not specifically asked for at the time of the original appointment. And if the patient and the doctor decide that a certified deaf interpreter is not necessary, then they can dismiss that person at that time. I also think it's important that physicians stop relying on family members to fill out paperwork or give important screening information. And as I mentioned before, the screening can, if you are developing screenings, you can consider adding ASL videos to disseminate with the results of those screenings. And then lastly, I would mention that when the patient is returning for a subsequent visit with the doctor, have a brief moment of knowledge confirmation to make sure that they understand that the screening result had come back and identify any gaps in their understanding and be able to fill those. I think all of those are options that clinicians would be able to implement tomorrow for the community.
Thank you very much. I don't see any additional questions in the Q&A. So thank you very much for your presentation. And I will move on to introduce our next speaker.
And
So
LaShondra, we
next,
do have one question that came through if you want to ask that before we move on.
oh, okay, let's see. Okay, the question I believe reads, I would love to learn more about an ASL video in the patient portal. How does this occur?
That's a great question. It's not yet happening. We need to make it happen. There are some physicians, I believe at the University of Rochester Medical Center, their emergency room, if I remember correctly, they are in the process of implementing that, in which they are making ASL versions of the results that would be likely put there in the portal. And that is unique to Rochester. And I think that that could be implemented on a larger scale across the United States to ensure these gaps are being closed.
Great. And we have one more comment from Anil Wali. It says, "Dear Dr. Poorna, it was a true pleasure and honor in meeting with you in person at the annual AACR meeting a couple of years ago at the NCI booth. This is a wonderful service to do, the patient navigation in diverse settings, diverse healthcare settings. My question is, would it be possible to utilize UN style of interpretation under these circumstances?"
Can you clarify the UN style? Do you mean a language other than American Sign Language?
I think what they mean is the style of interpretation used by the United Nations.
The interpreters at the United Nations use something that we call Gestuno or International Sign. It is not a bona fide language system, and it is not widely used within the community. So I would not recommend using that particular sign system. It would be best to ask the deaf patients what their preferred mode of communication is. And that is why I mentioned the certified deaf interpreter. Those interpreters are specialized. They are deaf themselves and have a shared experience. And they also have a wide range of language use that they could be more flexible with the deaf patient's needs.
Thank you very much. Next, we will hear from Dr. Gabriela Buccini. She is an assistant professor at the University of Nevada, Las Vegas School of Public Health, a trained maternal and child health and nutrition epidemiologist and implementation scientist. She leads federally funded mixed methods research focused on infant feeding, food insecurity, and early childhood development. Her work emphasizes the evaluation and scaling up of evidence-based interventions in low-income populations in the United States and globally. Dr. Buccini earned her master's degree and Ph.D. in nutrition and public health from the University of Sao Paulo in Brazil and completed postdoctoral training at the Yale School of Public Health, and she is an international board-certified lactation consultant. Dr. Buccini.
Thank you, Alexandra. Can you guys hear me okay? Yes? Okay, wonderful. All right, so it's my pleasure to be here. Thank you so much for organizing this exciting event. And it's the first time we are sharing this preliminary results, so I'm excited to see how people will react and how we can move forwards disseminating these results. So today I'm going to present the community nurturing care navigation to address maternal child food insecurity. You can go next, please. So here's just a little bit of an outline, pretty quick. We will go through the problem, where and who we work with, how we co-create this intervention, how we pilot it, and then a few conclusions. You can go next, please. All right, so starting with our problem. So household food insecurity is defined as the limited or uncertain access to sufficient food for an active life due to financial constraints. And in 2024, it affected 6.7 million US households with children. Household food insecurity affects child development by increasing toxic stress and consequently increasing adverse childhood events, and also disrupt parenting ability to provide nurturing care, which consists of providing health, nutrition, security, and safety opportunities for early learning, and also responsive parenting. So under this premise, we were hypothesizing that if we could empower families, services, and neighborhoods, finding the assets within these geographic areas, we could find community-based solutions for a problem that is a long-lasting problem. So moving next, please. So with that hypothesis, with that idea, we are located or working with communities located in the other side of what we call the other side of Las Vegas Strip. Everybody knows the Strip, and Las Vegas is famous for its tourism, but we do have areas where we need attention. So we partner with Nevada Partners at the time, who at the time coordinated a multi-sectoral initiative that calls the West Las Vegas Promise Neighborhood. And this initiative was focused on 5 priority zip codes that includes the historic west side of Las Vegas, which consists of high poverty census tracts in the city of Las Vegas. And at the time, those regions also had the higher levels of food insecurity among households with children under 3. However, this large multi-sectoral initiative, they didn't have a maternal child health component. So what we did, we partnered with them, and we brought our research team, a clinician team. You can go next, please. A clinician team to start thinking together with these multi-sectoral services, plus the resources and the ideas and information that we had. How could we solve maternal child health, food insecurity in those areas? You can go next, please. So in order to do that, it wasn't easy. We went to the community, we met with community leaders, we met a lot of organizations that were not initially involved in the West Las Vegas Promise Neighborhood Initiative. And we talked to them, and we proposed them to sit down and think through what solutions could be feasible to address this problem. So we formed a community advisory board with 18 organizations plus members, individuals of the community who had lived experience, who had experienced food insecurity at some point of their life. With this group, we met together, we gathered together in a 2-day meetings, very long meetings, where we develop a concept mapping, which is a participatory approach. And we discussed solutions. What would be solutions that we could address maternal child health? We emerged, you see here in this step 1 figure, some concepts that should be included in any intervention that we would be proposing. So we developed a consensus building process. You can go next, please. Yeah, thank you. Where we decided as a group all together that the intervention, any intervention that we would be developing would have 2 main components. One was universal food insecurity risk screening, and the other component would be referrals and follow-up. And in order to operationalize those 7 components, those 7 topics that we found through the concept mapping, and incorporate these core functions that we decided, we developed 3 levels of implementation strategies. We developed one that was community-led, the community workshops, another one that is more healthcare-led, the healthcare quality improvement. And today, what I'm going to share with you, next please, is the one that we develop at the individual level, which is the Nurturing Care Family Navigator. You can go next, please. So what do we know, what do we knew about nurturing care or navigation for families? We knew that it was a patient family navigation. It's a behavior focus and longitudinal intervention. We knew that this could be used for chronic conditions such as cancer, we just watched it, or diabetes, but we didn't know how this could be incorporated to reduce maternal child food insecurity, specifically during the postpartum period, up to 1 year postpartum. So we developed this intervention with a goal of thinking about not only the women in postpartum, but the entire family, and to increase their knowledge and self-efficacy, to navigate barriers across the 4 pillars of food insecurity and improve levels of food insecurity at the end of the day. To do so, to develop this intervention, we use 3 main guiding frameworks. So the first one is the nurturing care framework, which is our roadmap. We knew that we had to have components of health, nutrition, early learning, security and safety, and responsive caregiving. And we use it our core principle or our core functions: screening, referrals, warm hands-off, and coordination and follow-up. And we also integrated a social cognitive theory to have a behavioral health change theory to back up our goals and the way we would operationalize the intervention. Can go next, please. So based on that, we developed a randomized control trial that is registered in the clinical trial, and we used a mixed methods approach where our quantitative data is really driving the results, but we brought qualitative data to understand why we reached a specific goal or not reached another goal. Our target population, as I mentioned, was low-income, pregnant, or recent moms that were either Medicaid or uninsured, and they have a baby up to 14 days. They need to live in Clark County. We actually started focus on the 5 priority zip codes, but because Clark County had a very similar rate of maternal child food insecurity, we decided to expand and to benefit a large portion of the population. Our target sample for this specific study, since it was a pilot, it was 72 participants. The way the groups were assigned is intervention group received an educational package that included a workbook and a list of resources, and also one-on-one tailored navigation sessions that will occur via phone or text message. The control group received only the workbook and a list of resources. You can go next, please. So here is like a little bit of what these entail, what the intervention entails. So the participant workbook that was provided to everyone had a list of sessions or information sheets about these different topics. So we had this food access, postnatal care, infant feeding. So everyone received a list with information and resources regarding all those topics. But the intervention, it was receiving a little bit more. So they were receiving in every single interaction, they were screened either for food insecurity and other needs that they may have. They were walked through community resources, community services that could help them with a specific need that was screened. And we had a lot of follow-up and continuation of care by doing a warm hands-off, by calling and connecting them with a specific person in a service that they need. As we were doing this, we were addressing several of the sociocognitive theory constructs, as you see in this slide. You can go next, please. So we also had the nurturing care family navigators who were the ones delivering this intervention to the participants. They were all master's level or master's level training, female. They aged between 25 and 45, bilingual, and they had a background in maternal child health as well. One thing that was very innovative, I believe, in this process, we had our members of our community advisory board providing training to our nurturing care navigators. So it was really driven by the community. What does the navigator need to know in order to serve this community? And we had these different topics, as you see here: cultural humility, understanding the community, lactation, postpartum. Alongside with these more like formal trainings, we had a supervision that will occur weekly. In this supervision, myself as the PI and the whole team came together to discuss adverse events, professional boundaries, some things related to ethics, laws, guidelines, and all the sessions were monitored through a care navigation fidelity function to make sure that the sessions were delivered similarly across the different navigators. Can go next, please. So this is a simplified navigation conceptual model. So you will understand how we are conceptualizing the intervention and how the intervention links to the intervention outputs and intervention outcomes that I'm going to show to you. So the navigators, they deliver the intervention using the workbook through the navigation sessions. They have to use the core functions, as I mentioned, and the process based on the sociocognitive theory, which would then lead to an increased self-efficacy of participants, reduce barriers to food insecurity, and this would lead to our main outcome, which is reduced levels of food insecurity, as well as improve health outcomes such as mental health. And I'll also show you breastfeeding, which was another one that we included. You can go next, please. So the pilot timeline is being a year. So we began data collection and recruitment January last year, and we ended December 2025. So we reached our goal of 72 participants in December. And all participants are going through the same timeline. So they have an intervention session, so 12 intervention sessions that happen within the first 3 months. They have three follow-up sessions that is mostly checking, making sure they are engaged in the study and making sure we retain them over time. And then we will have a post session, which we have a 6 months period before the end of the study. You can go next, please. So right now we have completed the baseline and the time to data collection. The other time points of data collection are still ongoing. So what I'm going to show to you is essentially the difference between time 1 and time 2. So all the quantitative surveys were done via phone, and it will be comparing baseline and time 2. And the qualitative interviews were done after the intervention ended, also at time 2. So here is just a little bit of a participant flow, so you understand how many people completed the time 2 and how many people completed the interview. We can go next, please. So for quantitative data analysis, we did a little bit of descriptive analysis. I will show you the independent sample t-tests that we've done to compare between group differences, also within group difference. The statistical significance that we are considering is at 5%. And for qualitative analysis, we did in-depth interviews, and we are using the HEAIM to guide our thematic analysis. This table is a selected variables that I chose to show to you today as preliminary results of our trial. So we will talk about intervention outputs, intervention outcomes, and some health outcomes as well. You can go next. Thank you. Next, let's go to the results. So here is the demographic table, and mostly I just want to show you that we didn't have any difference between intervention and control group. As you see, we had 35 individuals in the intervention group and 37 in the control group. So no statistical difference. And we had here an average completion session by the intervention group 11 out of 12, which is a pretty good number, and it's actually higher than we were expecting. You can go next, please. So I will begin with discussing the intervention outputs. So I will begin with change in number of barriers to food insecurity. As you see at the beginning, at the baseline, both groups were pretty much at the same level. And then we see a significant decrease in the intervention group. So we had a lower number of barriers at time 2. And this was significant even when we look at between groups. And I just want to highlight one of the quotes here. So I do wish to time to time look back at the barriers, like the first session. And at the end of the 12 weeks, I didn't have those barriers anymore. So it really highlights what we see in the quantitative results. We can go next, please. In terms of the self-efficacy score, we did find a marginal, almost significant change in terms of their score, with the intervention group increasing slightly more than the control group, remembering that everybody had access to the workbook with information, which may have influenced a little bit the trends here in terms of score. But I want to read a quote that highlight a little bit what this means. So I know that is a lot of resources out there. We just have to know how to ask. And I guess even learn to ask, because I didn't know that stuff like that exists. So now I will be like, that has to be something out there for whatever we need. We just gotta ask and look. We can go next, please. In terms of intervention outcome, the main outcome, it was change in food insecurity. And as you see, both groups decreased the number of questions that they responded positively to food insecurity. So both changed significantly, but the change between groups was marginal. Again, it might be something related with our sample size, or we can test, we plan to test in different ways as well. But one important thing that I want to highlight here is that the intervention group did move from very low food insecure to food secure, which is like huge, and it was what we were expecting, although the change between groups is not that significant. And I want to read the quote to exemplify this. So yeah, I think one of the main resources was the food bank, because it was during the time where the government was shut down, and they sent me the information for the food banks. So that helped me to get a lot of food, and we still have some of the food from the end. So I haven't need a lot of even now. So I think that was the most helpful, just getting food, because we do have a big family and they go through it fast. We can move next, please. In terms of our intervention health outcomes, this is both ways that we measured mental health. So the first one is the EPGS, which is used after in the postpartum period, and the other one is the PHQ-2, but both showed similar results, with intervention decreasing slightly the score, whereas the control group increased it a little bit in both sides. Although the increase wasn't significant within groups, in between groups, we do see a difference. So I want to read a quote to show how people felt regarding the intervention. I personally felt supported emotionally because a lot of questions were about me, and I guess postpartum, even family. Even though I was with my mom and my husband, they don't really ask how we are doing, you know? So it was like a check-in for me too. She, the navigator, was really good, kind, and helpful. Next, please. The other mental health outcome that we measure was the anxiety score. And here we also see the same trend as we saw with the depression. So I'm going to read a quote so we can see how people felt. So I feel more empowered regarding resources, where to go and where to find them. I can feel confident without having to worry about it, knowing that these resources exist. So it really shows that even lives of anxiety through education and support, reduce it within the intervention. Next, please. In terms of the other health outcome that we were interested, we chose exclusive breastfeeding to show today, although we didn't find an association. We did see a trend where the intervention group sustained the exclusive breastfeeding and the control group did decrease slightly. So a quote to illustrate a little bit of this was like, I learned how to store your breast milk while you are not at home, was really helpful. And then also, I didn't know about Nevada laws regarding breastfeeding and pumping while at work. So those were really helpful and educational to have. We can move next, please. So what are our key lessons learned so far? We did see significant improvements in terms of reducing barriers to food security. And we saw it preventing maybe buffering effect on mental health, while we didn't see an improvement in the intervention group, control group worst over time. We did see marginal improvements between group in terms of increase in self-efficacy and decreasing food insecurity, again, highlighting that the intervention group did move from very low food insecure to food secure. We did not see improvement, so no direct effect on exclusive breastfeeding. So it might be something that we see long-term, or it really may not have any effect. We will see with time 3 when we get there, time 3 data collection. So I think those are the main key finds that I want to share. I think next, please. I want to thank you, my team, and I know they are here watching, so I want to shout out all of them, my navigators, my staff, my consultants, NIH project scientists that are part of this project, my partners. As I told you, we began with one community partner, and today we have so many actively engaged with data collection, with making sure that our intervention is community-led. It is a community-based solution. So I'm very thankful for all of them, and NIH for the award, of course. Next, please. Thank you.
Thank you very much, Dr. Buccini. We have time for one question, and it reads, during your concept mapping session deliberations with the Community Advisory Board members, did you perform ranking and sorting of the bold ideas in terms of go zone about the ideas that would be most feasible and most important in implementing these concept mapping ideas?
Yes, we did. And in the paper, we have that outlined and more detailed, but we did. And one thing that was really interesting is that the 3 implementation strategies that we ended up choosing to implement, we were able to merge all the feasible ideas that emerged from there. So although I presented as 3 different strategies, we were able to incorporate all the concepts and all the information that was raised through the concept mapping. It is a fun activity. They loved, they engaged, they still remember, like right now, about their participation and how intense and transformative that was for them to understand the problems and their assets.
Thank you. Thank you very much. There are a few other additional questions that were raised, and we will ask our speakers, we will send those questions to them and ask them to respond directly to those who ask those questions. Thank you very much to our speakers. Thank you, Dr. Kushalnagar, and thank you, Dr. Buccini. On behalf of the NIH Common Fund, I'd like to extend our gratitude not only to our speakers, but to all of you who have joined us today for this first Discovery Dialogues webinar. Today's presentations truly reflect the mission of the NIH Common Fund, especially our Transformative Health Disparities program, and our mission to support innovative, collaborative research that not only advances scientific knowledge, but also makes a tangible difference in health. If you'd like to know more about our Discovery Dialogue series or the Common Fund, please visit our Common Fund website. And before you leave, we ask that you kindly take a moment to complete a brief feedback survey. Your input will help us improve future webinars and better serve our participants. And the link to the feedback survey should be dropped in the chat. Thank you again very much for joining us today. We look forward to seeing you at a future Discovery Dialogues webinar. Have a wonderful afternoon. Bye-bye.